What if I told you that a seemingly benign tumor could just sort of detach itself from a patient's distal femur, enter the venous system, travel all the way through the right side of the heart, and then, lodge itself permanently inside the lung parenchyma, and we would still, like, clinically and pathologically call it completely benign?
I mean, it sounds like a total contradiction in terms, right? It basically breaks
Okay.
every single
Okay.
traditional rule of general oncology that we're taught back in medical school.
Yeah, exactly.
But, in musculoskeletal pathology, the vocabulary we use, words like benign and malignant, they can be incredibly, almost dangerously deceptive.
And that deception is, well, it's exactly why we're dedicating this entire deep dive to musculoskeletal oncology. So welcome to the show.
Thanks for having me.
If you're tuning in right now, you are likely, right in the thick of it. You're preparing for the FRCS and trauma and orthopedics. And let's be entirely realistic about your current situation, right? You are almost certainly not sitting at a quiet mahogany desk with a nice textbook and a 4-color pen.
No, absolutely not.
You're probably gripping a steering wheel on the M1 or, cycling home from a really grueling on-call shift. Or maybe you're just trying to fold a mountain of laundry while keeping your revision on track. So your eyes are busy, your hands are tied, and your ears are basically doing all the heavy lifting right now.
Which is actually the exact right modality for this specific subject, to be honest.
Really? Why is that?
Well, because if you try to, visually memorize those massive textbook tables of orthopedic oncology, the endless eponymous syndromes, the obscure chromosomal translocations, all those cellular markers, I mean, you will just drown. It's totally overwhelming.
It's just diagnostic muddy waters.
Yeah, exactly.
Yeah.
But the truth is, the exam and, frankly, safe consultant-level clinical practice, it doesn't require you to just recite a dictionary of rare soft tissue sarcomas.
Right.
The examiners they only care about two fundamental questions when you're faced with any kind of bony or soft tissue lesion.
Just 2 anchor points, basically.
Yeah, just two.
So question number 1 is, how does it behave? And that's the essence of staging, right?
Exactly.
And question number 2 is, how much do I actually need to take out? And that dictates your surgical margins. So if you understand the biological rationale behind those 2 specific questions, you have the scaffolding, you can, hang any specific weirdly named tumor onto that framework, and the clinical management will just sort of logically reveal itself.
It really will.
Yep.
And because we know you can't take notes right now, we're basically going to act as your audio highlighter today.
Yes, our ground rule for this deep dive.
Right, the ground rule. So every time we hit a critical staging system or a vitalist or a really high-yield exam discriminator, we're going to state it clearly, and then we are going to, organically double back and repeat it.
Twice. We'll say it twice.
Yeah, exactly, twice. We want that auditory-spaced repetition to really lock these frameworks into your short-term memory, just so they survive until the exam.
Perfect. So let's jump straight into the first half of that core framework. Question 1, right? Staging and behavior.
Yeah, let's do it.
So we have this unknown lesion on an X-ray. We need to know exactly how it's interacting with its local environment before we even, think about touching it with a needle or a scalpel.
Right, and the overarching system you absolutely have to know inside and out for this is the Enneking system.
Okay, Enneking.
Yeah, Enneking. You'll also see this referred to in the literature and actually in a lot of multiple choice questions as the Musculoskeletal Tumor Society staging, or MSTS staging.
MSTS, got it.
Now, the defining genius of the Enneking system is its strict biological dichotomy. It doesn't try to mash everything together onto one big continuous scale.
Yeah.
It's divided strictly into 2 completely separate systems. So you have one framework for benign lesions and a totally distinct, separate framework for malignant lesions.
Okay, wait, I need to play devil's advocate here for a second, just acting as, the senior registrar taking this exam.
Sure, go ahead.
Because Enneking originally published this staging system back in, 1980?
Yeah, around then.
And we are now in an era of, whole genome sequencing, advanced molecular markers, targeted immunotherapy. Why are we, as modern orthopedic surgeons, still relying on this 40-year-old system of Roman numerals and letters to decide if we need to amputate a patient's leg?
Look, it's a totally valid challenge. I mean, it sounds archaic, right? But the reason Enneking survives and the reason the FRCS just tests it so relentlessly is because orthopedic oncology is ultimately a mechanical and anatomical discipline.
Mechanical, how so?
Well, no matter what the genetic sequencing tells you about a sarcoma, the physical anatomy of the limb is what dictates the surgery. Enneking understood that the body creates these natural biological firewalls,
Yeah.
things like fascial planes, the periosteum, articular cartilage.
Right, the physical barriers.
Exactly. His staging system is entirely based on whether a tumor respects those physical firewalls or whether it just burns right through them. The molecular signature tells us what the tumor is, sure, but Enneking tells us what the surgeon actually has to do about it in the operating theater.
Ah, okay. That makes perfect sense. The anatomy dictates the scalpel.
Exactly.
So let's take the benign system first. How does Enneking categorize lesions that are, biologically speaking, non-cancerous?
So for benign tumors, the Enneking system uses Arabic numerals, just your standard numbers 1, 2, and 3. And this staging is based entirely on a spectrum of local activity. Like, how aggressively is this benign tissue behaving in its immediate bony environment?
Okay, let's break down that spectrum, starting with the quietest end.
Yeah, so stage 1 is latent or inactive. Think of this as a completely dormant resident just sitting in the medullary canal of the bone.
So it's not really doing anything.
Right, it produces absolutely no symptoms. The patient has no resting pain, no night pain, no mechanical pain. And crucially, it's not growing. The biological activity has just burned out.
So if it's asymptomatic and not growing, how do we even know it's there?
Well, almost always. It's just an incidental finding. Like, say a 25-year-old patient rolls their ankle playing football, right? They come into the emergency department, you order an x-ray to rule out a lateral malleolus fracture, and you just happen to see a non-ossifying fibroma sitting quietly in the distal tibia.
Oh, I see.
Yeah, and the margins on the x-ray will be really sharp, heavily sclerotic, which means the surrounding normal bone has had plenty of time to build a thick, dense wall around it.
Got it. So what's the treatment for that?
The clinical action for a stage 1 latent lesion is almost always just to observe it, or honestly, more likely, completely ignore it and just reassure the patient.
Okay, so stage 1 is latent, quiet, heavily walled off. What causes a benign lesion to, tip over into stage 2?
So stage 2 is active. Now the lesion is woken up biologically. It is symptomatic.
So the patient feels it.
Yeah, the patient is coming to clinic complaining of a dull, deep, aching pain. And on the x-ray, you can see that it's growing. It's actively resorbing the host bone. So those margins we talked about will be less sclerotic and a bit more ill-defined. It might be thinning out the cortex or even causing the bone to subtly expand outwards.
But there is a hard boundary here, right?
Yes, and this is the absolute key to stage 2. It is still completely contained within the anatomical compartment of the bone.
Okay, so it hasn't broken out.
Right. The cortex might be paper thin, but it's entirely intact. It has not breached. To use an analogy, it's like an active fire burning inside a fireplace. The bricks are getting incredibly hot, but the fire is still technically contained within the hearth.
That's a great way to picture it. Okay, so stage 1 is latent and dormant. Stage 2 is active, symptomatic, but strictly contained, which brings us to the top of the benign scale.
Yeah, stage 3 is aggressive. This is where the benign tumor basically stops respecting those natural biological firewalls.
The fire leaves the hearth.
Exactly. It physically breaches the cortex of the bone and extends outwards into the surrounding soft tissue compartment. Or alternatively, it destroys so much structural integrity that the bone just snaps under normal physiological load.
A pathological fracture.
Exactly. A pathological fracture instantly opens the door, mechanically spilling the tumor contents out of the bone and into the surrounding hematoma.
Wow. So even though the cells under the microscope look perfectly benign-like, they aren't mutating, they aren't pleomorphic locally, the tumor is acting like a wrecking ball.
That's exactly it. A stage 3 benign tumor will relentlessly destroy local anatomy. And crucially, if you try to simply scrape a stage 3 lesion out, it has an incredibly high rate of local recurrence. It behaves aggressively, even if it lacks the biological machinery to metastasize and kill the patient.
Okay, let's lock this benign framework in. If I'm driving right now, I need to hear that sequence clearly so it sticks. So let's run through the benign Arabic numbers one more time.
Okay, so the benign Enneking stages use Arabic numerals. Stage 1 is latent, it's asymptomatic, incidental, heavily sclerotic margins, and we observe.
Stage 1 is latent.
Stage 2 is active. It's symptomatic, growing, thinning the cortex, but strictly contained within the bone.
Stage 2 is active and contained.
And stage 3 is aggressive. It has breached the cortex, extended into the soft tissues, or caused a pathological fracture.
Stage 3 is aggressive and breached. Okay, perfect. Stage 1 latent, stage 2 active, stage 3 aggressive. Now, the sources highlight a very specific, high-yield worked example that the exam absolutely loves to use to test whether you truly understand this benign staging. Let's look at a clinical scenario involving a giant cell tumor, or GCT.
Yeah, this is a classic FRCS setup. Imagine you have a 30-year-old patient who presents with escalating pain in their knee over the last 3 months.
Okay, so right away, they're symptomatic.
Right. You get an X-ray, and you see a lytic, destructive giant cell tumor in the distal femur. The bone is significantly thinned out, and the distal femur looks slightly expanded or ballooned. But when you look closely at the MRI, the cortical rim, even though it's paper thin, is continuous.
It's holding.
Yeah. There is no soft tissue mass outside the bone, and the patient has not suffered a fracture.
Okay, let's apply the logic here. It's symptomatic and growing, which immediately rules out stage 1 latent.
Correct.
But the cortex is still physically intact, keeping the tumor inside the bone, and there's no fracture, which means it hasn't met the criteria for stage 3 aggressive.
Spot on. So because it's symptomatic but still contained, this specific giant cell tumor is classified as a stage 2, an active lesion.
But the clinical reality can change in a split second.
Oh, absolutely. It
Yeah.
can change with a single misstep off a curb. If that 30-year-old patient just twists their knee and that paper-thin distal femur snaps, causing a pathological fracture, the tumor instantly spills into the surrounding muscle and joint space. And in that split second, the biological nature of the giant cells didn't mutate. But the staging escalates instantly to a stage 3 aggressive lesion, because containment has been lost, and the surgical management changes dramatically.
That distinction between the biology of the cell and the mechanical reality of the anatomy is just fascinating. Okay, let's shift gears. We've mastered the benign Arabic numerals. What happens to the Enneking framework when we cross the line into the malignant system?
Well, the malignant Enneking staging system abandons Arabic numerals entirely and uses Roman numerals, I, to, and here.
Roman numerals, okay.
And instead of just looking at local containment, this malignant system hinges on a matrix of 2 primary factors: histological grade and anatomical location.
Grade and location. So how do the Roman numerals map onto the grade?
So stage on, Roman numeral I, signifies a low-grade malignancy. Under the microscope, these cells still look somewhat similar to their tissue of origin. They're well differentiated. There are fewer mitotic figures, meaning they're dividing more slowly.
So they're dangerous, but slower.
Right, they're relatively indolent for cancer. Then you have stage 2, Roman numeral II. This signifies a high-grade malignancy. These cells are biologically wild. They're highly pleomorphic, meaning they look nothing like normal cells. They are rapidly dividing, and they have a high propensity to jump into the bloodstream. These are your aggressive osteosarcomas and Ewing sarcomas.
Got it. E is low grade, 2 is high grade. What about 3?
Stage 3, Roman numeral III, is basically the ultimate trump card in the system. Stage 3 means the tumor has metastasized.
Oh, okay.
And here's the key. It does not matter if the primary tumor was originally low grade or high grade. The moment there is a distant metastasis, like a deposit in the lungs or a skip lesion in another bone, it automatically bypasses everything and becomes stage 3.
Wow. So the Roman numeral tells you the histological grade I for low, 2 for high, unless it has spread to the lungs, in which case it's an automatic 3.
Exactly.
But you mentioned location was the second half of the matrix. Where does that come in?
Location provides the letter that attaches to the Roman numeral. Specifically, Enneking forces us to look at anatomical compartments. A compartment is a 3-dimensional space bounded by those thick, natural biological barriers we mentioned.
Like the bone itself.
Yeah, the medullary canal of a bone is a compartment, bounded by the thick cortical bone. The anterior muscle group of the thigh is a compartment, wrapped tightly in dense fascial septa.
Okay, so how do the letters work?
We use the letter A to denote intracompartmental. This means the malignant tumor, regardless of its grade, is entirely trapped inside its original anatomical compartment. The barriers have held.
A is inside.
And we use the letter B to denote extracompartmental. This means the tumor has burst through the cortical bone or burned through the deep fascia and has invaded the loose, surrounding uncompartmentalized spaces or crossed into a neighboring muscle group.
B is outside. Okay, so to put this together in a clinical vignette, if I have a 15-year-old patient with an osteosarcoma, which we know is inherently a high-grade malignancy, and the MRI clearly shows that the tumor has destroyed the cortex of the proximal tibia and is now forming a large fleshy mass in the anterior tibialis muscle, what is the exact stage?
We just build it systematically.
Right.
So it's a high-grade sarcoma, so that gives us Roman numeral II.
Right.
It is burst out of the bony compartment of the tibia and into the muscle, so that gives us the letter B. It is a stage IIB.
Stage IIB. Okay, let's do the organic repetition for the malignant framework. If I'm listening on my commute, let's really cement the Roman numerals and letters.
Sure. Malignant stages use Roman numerals. Stage 1 is a low-grade tumor. Stage 2 is a high-grade tumor. Stage 3 means it has metastasized, overriding the grade.
Roman I low, 2 high, 3 mids.
And for the location modifiers, A means it is intracompartmental, contained by natural barriers. B means it is extracompartmental, having breached those barriers.
A is inside, B is outside.
Okay, now, this all seems highly logical when we discuss it calmly on a podcast, on a deep dive.
Yeah.
But the sources point out a very specific, devastating trap that the exam setters lay for candidates here.
Oh, it's brutal. It is a trap of pure visual and mental fatigue. Under the intense time pressure of the FRCS, your brain starts taking shortcuts.
Yeah, you just want to get through it.
Right. And the examiners will deliberately mix up the Arabic numbers and the Roman numerals in the multiple choice options. They will describe the exact clinical vignette we used earlier. You know, a benign contained giant cell tumor in the knee.
Right, the stage 2 active.
Exactly. And the options will include stage 2 with the Roman numeral right next to stage 2 with an Arabic number.
Oh, that is sneaky. And if you're rushing and you just think 2 in your head, you click the Roman numeral 2 and you instantly fail the question. Honestly, it's worse than just failing a question. You are demonstrating a profound lack of safe clinical knowledge. By clicking Roman numeral 2, you are essentially telling the examiner that you cannot tell the difference between a locally active, benign giant cell tumor and a deadly high-grade osteosarcoma.
That is a massive difference.
It's a dangerous error. You must keep the fonts strictly separated in your clinical mind. Arabic is always benign. Roman is always malignant.
Okay, I want to throw out a spoken analogy to conceptualize these A and B letters for the listener, just to paint a vivid picture in their mind's eye. Let's go back to that idea of a house fire.
Okay, let's hear it.
So the A stage, the intracompartmental lesion, is like a massive fire being contained entirely within the kitchen, with the heavy fire door shut tight. The kitchen itself is being absolutely destroyed, right? The heat is immense. But those thick walls and that heavy door, which represent the periosteum or the deep muscular fascia, they are holding strong. The fire is strictly inside that one specific room.
That is precisely what is happening biologically.
Yeah.
The body's firewalls are holding the line against the malignancy.
And then the B stage, the extracompartmental lesion, is when the fire has finally burned through the drywall. It has melted the hinges off the door, and the flames are now rolling out into the main hallway of the house, accessing the stairwell, and threatening entirely new areas of the property.
Exactly. And just like a real house fire, once the flames hit the main hallway, the speed at which the devastation spreads increases exponentially. From a surgical perspective, trying to manage a fire isolated to a kitchen is a localized problem.
Right.
But trying to extinguish a fire that is rolling down the hallway requires you to tear down half the house.
Which perfectly transitions us to the surgical reality. If you forget everything else we just discussed about staging, lock in this fundamental rule. Benign tumors are stage 1 latent, 2 active, 3 aggressive, and a contained giant cell tumor is a stage 2. Malignant tumors are I low-grade, 2 high-grade, 3 metastatic, with A intracompartmental and B extracompartmental.
That is the absolute foundation of behavior.
So, if we accept that a stage 3 or a stage IIB tumor has completely breached its local environment, the next logical hurdle is figuring out how to cut it out without leaving a single microscopic cancer cell behind. Which brings us to the second anchor question. Margins. How much do you actually take out?
Right, and this is where the Enneking staging system shows its true clinical value. Like, it doesn't just stop at giving you a neat diagnostic number or letter. The stage dictates an algorithmic relationship to 4 distinct surgical margins.
Well, margins, okay.
And these margins increase sequentially in their severity and, honestly, in the sheer volume of tissue you are removing from the patient's limb.
Let's walk through these 4 margins meticulously. So the first, and I guess most minimal surgical approach, is the intralesional margin.
Yeah, an intralesional margin means exactly what the Latin suggests. You are going directly into the lesion. Your surgical instrument, which is typically a sharp curette, physically breaches the outer wall of the tumor, enters the main mass, and you just aggressively scrape it out from the inside, kind of like scooping the flesh out of a melon.
But biologically, if your instrument is inside the tumor, there's a major consequence to that.
Oh, absolutely.
Huh.
By definition, an intralesional margin leaves microscopic disease behind in the patient. You are physically smearing cells against the bony walls of the cavity.
Oh, I see.
You might remove 99% of the bulk, but you are leaving a microscopic film of tumor. Therefore, this margin is only ever appropriate for something entirely benign and non-aggressive, like a stage 1 latent simple bone cyst, where leaving a few cells behind carries literally zero risk of malignant recurrence.
Right, you're scooping it out, but the spoon touches the bad stuff.
Exactly.
Now, the second margin escalates the clearance. It is called the marginal margin. That phrasing sounds incredibly redundant, honestly.
It does sound like a tautology, I agree, but marginal here refers to a very specific anatomical plane of dissection. With a marginal resection, you are dissecting right along the very outer physical edge of the tumor. You are shelling it out in one piece by cutting through what is known as the reactive rim, or the pseudocapsule.
Okay, let's clarify that for the listener, because the term pseudocapsule is thrown around a lot. What exactly is a reactive rim physically made of?
So when any tumor grows, whether benign or malignant, the body's healthy surrounding tissue reacts to the invasion. The local host tissue gets inflamed, there's massive localized edema, neovascularization, and the body attempts to wall off the invader by laying down a thin, compressed layer of fibrous tissue.
So it's trying to protect itself.
Right. That compressed zone of inflamed host tissue is the pseudocapsule.
But the prefix pseudo implies it's a fake capsule, like it's not a true seal.
Exactly. It's a biological illusion. It looks like a neat, glistening, impenetrable barrier to the naked eye of the surgeon. But under a microscope, it is highly porous. And more importantly, as the tumor grows, it pushes microscopic clusters of its own cells, which we call satellite cells, out into this reactive rim.
So they're hiding in the rim.
Yeah, so if your scalpel dissects perfectly through this pseudocapsule, you will lift the main tumor mass out, looking like a perfect intact sphere. But because you cut through the reactive zone, you have very likely left microscopic satellite cells behind in the patient's limb.
Okay, so an interlesional margin definitely leaves gross microscopic disease. A marginal margin dissects the reactive rim and frequently leaves satellite cells behind.
Right.
What if we're dealing with a stage IAB high-grade osteosarcoma where we absolutely, unequivocally cannot afford to leave a single microscopic cell behind?
Then you must escalate to the third margin, the wide margin. This is the absolute gold standard requirement for high-grade sarcomas. A wide margin means you take the entire tumor out whole, but it is surrounded completely by a continuous, unbroken, three-dimensional cuff of completely normal, healthy tissue.
Wait, so your scalpel never even gets close to the tumor?
Never. Your scalpel must never see the tumor. Your scalpel must never even enter the inflamed reactive zone or the pseudocapsule.
Yeah.
You are cutting entirely through normal, healthy muscle bellies, normal, healthy fat pads, and normal, healthy cortical bone. You give the tumor a very wide berth. The pathologist should receive a specimen where the cancer is buried deep inside a thick cocoon of normal tissue.
How thick does that cuff need to be? Like, is it a set millimeter distance?
That's a common question, but it's not about millimeters. It's about fascial planes. 1 millimeter of thick, robust, unbreached, deep fascia is a much safer, wider margin than 3 centimeters of loose, porous, subcutaneous fat. You are relying on those anatomical firewalls we discussed earlier.
And what if the tumor is so massive and has breached so many compartments that a wide cuff of normal tissue is just impossible to achieve while saving the limb?
Then you are forced into the final, most extreme option, the radical margin. A radical margin means you are not just taking a cuff of normal tissue, you are amputating or excising the entire anatomical compartment that the tumor sits in, from its absolute origin to its absolute insertion.
Wow. Give me a tangible example of what a radical margin looks like.
Okay, so if a patient has a massive recurrent sarcoma filling the anterior compartment of the thigh, so the quadriceps group, a radical margin requires detaching the entire quadriceps mechanism from the anterior inferior iliac spine of the pelvis all the way down to the tibial tubercle and removing the entire compartment as one massive unit. Nothing is left.
That is incredibly destructive, but I guess sometimes necessary to save the patient's life. Okay, let's lock this in organically. If I'm listening to this while cooking dinner, I need to cement these 4 escalating steps. Let's run through the 4 margins and their definitions once more.
All right, the 4 surgical margins. First, intralesional. Your instrument goes inside the tumor, leaving microscopic disease.
Intralesional inside.
Second, marginal. You shell the tumor out by dissecting through the pseudocapsule, potentially leaving satellite cells.
Marginal, through the rim.
Third, wide. You remove the tumor encased in a continuous unbroken cuff of completely normal, healthy tissue.
Wide, healthy cuff.
And fourth, radical. You remove the entire anatomical compartment from origin to insertion.
Intralesional through the middle, marginal through the rim, wide with a healthy cuff. Radical takes the compartment. Got it. Now, let's connect the two halves of our framework. Why did we spend so much time calculating the Enneking stage, only to jump into margins?
Because it is a direct, unforgiving algorithmic relationship. The Enneking stage dictates the margin choice. If you miscalculate the biological stage, you will inevitably choose the wrong surgical margin, and the patient will suffer.
Give me an example of how that actually goes wrong in practice.
Well, if you misdiagnose a highly aggressive stage 3 benign lesion, or worse, a low-grade stage eye sarcoma, and you treat it with a simple intralesional curettage, just scooping it out, it will roar back. It will recur locally.
Because you left cells behind.
Exactly.
Yeah.
And in oncology, when a tumor recurs locally, it almost always comes back with more aggression. The anatomy is heavily scarred from your first surgery, the natural tissue planes are destroyed, and your chance of saving the limb drops drastically. Escalating biological aggressiveness demands an escalating surgical margin to prevent recurrence.
I want to give the listener a visual, kind of a mechanical analogy for this to help differentiate the intralesional, marginal, and wide concepts.
Okay, let's hear it.
Imagine the tumor is a soft, rotting brown spot on a fresh apple. If you take a spoon and you just scrape the brown mush out of the center, that is your intralesional margin. You've removed the bulk of the rot, but the edges of the hole you dug are still a bit discolored, and you have definitely left microscopic rot right there in the flesh of the apple.
That's right. The cavity is completely contaminated.
Now, if you take a sharp paring knife and you carefully peel the rot out, tracing the blade exactly along the boundary where the brown mush meets the crisp white flesh, that is your marginal margin. It looks like a clean job, but you might have missed a tiny microscopic filament of rot, the satellite cell that extended just 0.5 millimeter into the white flesh.
Because you've gone precisely through the reactive rim.
Then, the wide margin. You take a massive butcher knife and you just chop off an entire third of the apple. The rotting spot is dead center inside the chunk you chopped off, completely surrounded by bright white, healthy, crisp apple flesh. Your blade never even got close to touching the rot.
That is the perfect wide excision. The rot is trapped in a cocoon of normal flesh.
And finally, the radical margin. You just throw the entire apple into the garbage bin.
Yeah, it's a slightly grim analogy when you apply to a human limb, but mechanically and biologically, it is completely accurate. You must match the aggression of your cut to the aggression of the disease.
But here's the massive catch that bridges us to the next critical topic. Before you can confidently declare an Enneking stage IIB, before you can finalize your plan to execute a massive wide margin, you have to find out what the tumor actually is on a cellular histological level.
Which means you have to get a tissue sample.
And that leads us directly into the danger zone, the biopsy.
The biopsy. This is, without any exaggeration, the most dangerous step in all of orthopedic oncology. It is the specific juncture where a well-meaning general surgeon or a trainee operating late at night outside of a specialist tumor center can do catastrophic, irreversible harm to a patient.
Okay, let's unpack this heavily. Why is a tiny little core needle or a tiny 2-centimeter surgical stab incision the most dangerous part of the entire process?
Because the fluid dynamics and the physical reality of a biopsy. The golden rule of oncology is this: the biopsy tract, meaning the physical, three-dimensional path that the needle or the scalpel takes from the surface of the skin, down through the fat, through the muscle, and into the tumor, instantly becomes contaminated with malignant cells.
Wait, how does the contamination actually happen?
2 ways. First, physical drag. As you pull the biopsy needle or the scalpel back out of the tumor, the instrument physically drags tumor cells up through all those healthy superficial tissue layers.
Just mechanically pulling them out.
Right. And second, fluid dynamics. You have just poked a hole in a highly vascular tumor. It bleeds. That bleeding forms a hematoma. And that pressurized hematoma acts as a liquid transport vehicle, forcefully tracking back up your biopsy path, pushing malignant cells into the surrounding healthy muscle and subcutaneous fat.
So the entire path from the skin to the bone is now seeded with cancer.
Precisely. Therefore, the cardinal rule is that the entire biopsy tract must be meticulously planned so that it can be completely excised in continuity with the main tumor mass during the definitive wide margin operation weeks later.
So if the definitive oncology surgeon cannot safely cut out your biopsy scar and the tract beneath it, they are forced to leave cancer cells in the limb.
Or, more tragically, if your biopsy tract is placed recklessly across vital structures, the definitive surgeon cannot cut it out without destroying the limb's entire function. A poorly placed needle basically converts a complex but achievable limb salvage surgery into a mandatory life-saving amputation.
So there are very strict technical principles to ensure that tract can be safely removed later. Let's walk through the mechanics of each one.
First and foremost, the incision must be strictly longitudinal. Your biopsy incision must run straight up and down the limb, perfectly parallel to the long axis of the underlying bone.
Okay, I am going to push back on this, playing the devil's advocate for an orthopedic registrar on call.
Sure, go for it.
If I'm looking at a superficial lump on the anterior aspect of someone's thigh, a transverse incision cutting horizontally across the leg might give me much better access to the borders of the mass. Furthermore, we know from basic plastic surgery principles that transverse scars heal beautifully, right? They follow Langer's lines, the natural tension lines of the skin, giving a neat cosmetic result. Why can't I just do a small 2-centimeter transverse incision, get the tissue, and leave a neat little horizontal scar right now?
Because a transverse scar on an extremity is a literal death sentence for limb salvage. It is all about the geometry of the definitive surgery.
The geometry.
Yeah, think about what happens weeks later. The definitive oncology surgeon has to execute a wide margin. To do that, they use a massive longitudinal elliptical incision, often 2 feet long, running up and down the leg to access the whole compartment. If you made your biopsy longitudinal, your little scar sits perfectly inside their massive vertical ellipse, and the whole contaminated tract is removed cleanly in one package.
Oh, I see. But if I made a horizontal cut...
If you made a horizontal scar across the front of the thigh, it sits perpendicular to the definitive incision. To safely excise your horizontal scar with wide margins, the definitive surgeon would have to cut a massive horizontal swath of skin and fascia that wraps halfway around the circumference of the patient's leg.
Which sounds impossible to close.
It is. When they finish the tumor resection and try to close the wound, the skin edges will be a foot apart horizontally. The tissue simply will not stretch that way. The skin flaps suffer tension necrosis, the wound breaks down, the massive metal endoprosthesis they just implanted gets infected, the reconstruction utterly fails, and the patient loses the limb. You literally trade a neat cosmetic scar today for a high above knee amputation tomorrow.
Wow. When you break down the geometry of the skin flaps like that, it makes absolute brutal sense. Longitudinal only. What are the other technical principles?
You must go through a single compartment. Do not be clever and pass your needle through an interior muscle, cross a fascial plane, and traverse a medial muscle just to get a better angle at the bone.
Because then you contaminate 2 areas.
Right, you've just artificially contaminated 2 separate compartments, and now the surgeon has to amputate both of them. Go straight in via the shortest route, strictly through the compartment where the tumor already lives.
Makes sense. What else?
Next, you must avoid the neurovascular bundle at all costs. Do not track near the femoral artery or the sciatic nerve. If your hematoma seeds tumor cells around the main artery or nerve of the limb, the definitive surgeon has no choice but to resect that artery or nerve to get a wide margin. And once you resect the main nerve to the leg, the limb is effectively useless.
You mentioned the hematoma earlier. How do we actually control that fluid spread?
Meticulous hemostasis is vital. You cannot just take the tissue, throw a stitch in the skin, and leave the deep tissues bleeding. You must achieve absolute hemostasis to prevent a pressurized hematoma from spreading cells far beyond your tract.
And what if we need a drain?
If you absolutely must leave a surgical drain in to manage the oozing, the drain must exit the skin directly in line with your longitudinal incision. It cannot exit out the side of the leg. It must be in line so that the drain hole itself can be captured and excised within that same future vertical elliptical incision.
This is arguably the highest stakes list in the entire exam syllabus because it literally dictates limb survival. Let's cement these biopsy principles. Let's run through the list organically one more time.
Okay, the biopsy rules to save the limb. Number 1, a strict longitudinal incision in line with the future definitive resection.
Longitudinal.
Number 2, traverse a single compartment only.
Single compartment.
Number 3, avoid the neurovascular bundles completely.
Avoid nerves and vessels.
Number 4, achieve meticulous hemostasis to prevent hematoma spread.
Hemostasis.
And number 5, any drain must exit in line with the primary incision.
Drain in line. And given all of this extreme risk, who should actually be holding the knife or the needle for this procedure?
The definitive literature is crystal clear here. The biopsy should ideally be performed by the exact same surgeon who is going to perform the definitive wide resection. Or at the very least, it must be performed at a specialist regional tumor center. The morbidity of a poorly placed biopsy by an outside non-specialist is simply way too high.
You protect the tract, you protect the limb. All right, we have built the foundational framework. We know how to stage the biological behavior using Enneking. We understand how that stage dictates the mechanical surgical margins. And we know the rigorous physical rules for safely acquiring the biopsy tissue.
Yep, the scaffolding is built.
So it's time for a quick pit stop to lock all of this architecture in before we transition to applying it. We're going to tackle the specific tumors the exam loves, but first, let's do a rapid consolidation.
Let's run it.
The scaffolding. Behavior. Benign uses Arabic numbers. Stage 1 is latent. Stage 2 is active but contained. Stage 3 is aggressive and breached. Malignant uses Roman numerals. Stage 1 is low grade. Stage 2 is high grade. Stage 3 means it has metastasized. The letter A means it's trapped inside the compartment. The letter B means it has burst outside.
Perfect.
Margins. 4 escalating biological steps. Intralesional scrapes through the tumor. Marginal dissects through the reactive pseudocapsule. Wide removes a continuous cuff of normal tissue. Radical amputates the entire compartment.
Spot on.
Biopsy. The golden mechanical rule is that the tract must be excisable. This mandates a longitudinal incision and meticulous hemostasis to prevent fluid tracking.
The framework is absolutely secured. Now we can take this theoretical scaffolding and apply it to the complex clinical realities of 3 specific named tumors that really dominate the sources in the exams.
Awesome. Let's start with the one we used earlier as our benign staging example, because it's arguably the most heavily tested mimic in orthopedics, the giant cell tumor, or GCT.
Oh yeah, the classic.
Let's paint a detailed clinical picture. Who is the patient, and where does this tumor actually strike?
The demographic profile for a giant cell tumor is highly specific. We're looking at young adults, typically between 20 and 40 years old.
Why that specific age bracket?
Because of skeletal maturity. GCTs almost exclusively occur after the growth plates, the feces, have fused and closed, and that relates directly to their defining radiological location. GCTs are classically epiphyseal. They occur at the absolute very ends of the long bones, right up against the joint space.
They're right near the joint.
Yeah, in fact, a hallmark radiological characteristic is that the lytic lesion extends all the way through the epiphysis, right up to the subchondral bone plate, effectively touching the underside of the articular cartilage.
And anatomically, where are the hot spots in the body?
The absolute classic textbook location is around the knee joint, so involving the distal femur or the proximal tibia. The second major hotspot you'll see in clinical practice is the distal radius at the wrist.
Okay, so if I'm looking at the x-ray of that 30-year-old's knee, what specific morphological features am I seeing?
The radiological description is highly standardized here. You'll see a lesion that is planolytic, meaning it is aggressively resorbed and eaten away the host bone, creating a dark, hollowed-out void on the radiograph. It's eccentric, meaning it's situated off to one side of the bone's axis, not sitting perfectly symmetrical in the dead center of the medullary canal.
Lytic and eccentric. Okay.
It's expansile, meaning the mechanical pressure of the tumor is actually causing the thinned cortical bone to bulge outwards. And the classic must-know buzzword is a soap bubble appearance. It looks like a cluster of dark, thin-walled, multiloculated bubbles trapped right at the very end of the bone, pushing up against the joint line.
A lytic, eccentric, expansile soap bubble at the knee in a 30-year-old. Got it. So what is the actual molecular biology driving this profound bony destruction?
To understand the destruction, we have to look at the cellular interplay, specifically the rank-ligand pathway.
The rank-rankle axis. This is fundamental bone metabolism.
Exactly right. Normally, a regular chemical signal that osteoblasts use to tell osteoclasts, which are the cells responsible for resorbing and breaking down bone, to activate. It's a tightly controlled physiological balance.
So what goes wrong in a GCT?
Well, in a giant cell tumor, that balance is entirely hijacked. And here's a nuanced point the exam really loves. The giant cells themselves are actually not the true neoplastic mutant cells.
Wait, the tumor is named after the giant cells, but they aren't the cancer?
Correct. The true neoplastic cells in a GCT are the relatively inconspicuous mononuclear spindle stromal cells. These mutant stromal cells furiously overexpress and secrete massive pathological amounts of the NAL protein.
Oh, I see.
Yeah, so this localized flood of NAL recruits normal, healthy, circulating macrophages, fuses them together into enormous, multinucleated, osteoclast-like giant cells, and just locks them into an overactive bone-eating frenzy. The tumor tissue becomes utterly packed with these hijacked giant cells which relentlessly resort the surrounding burn.
It is a brilliant, devastating biological mechanism. But, because we finally understand that specific molecular pathway, we now have a highly specific, targeted medical treatment for what used to be a purely surgical problem, right?
Yes, we do. This is one of the great modern triumphs of targeted translational medicine in orthopedics. We use a drug called denosumab.
Denosumab.
Denosumab is a synthetically engineered monoclonal antibody. It acts basically like a molecular sponge. It specifically binds to and neutralizes all that excess RNKL floating around in the tumor microenvironment.
Oh, it blocks the signal.
Right. By soaking up the RNKL, denosumab starves the giant cells of their activation signal. The giant cells undergo apoptosis and die off. The aggressive bone destruction stops in its tracks, and the host bone is allowed to heal, causing the periphery of the tumor to harden into a dense, calcified rind.
That is incredible. A drug that literally turns off the bone-eating machinery. Okay, let's recap those core GCT discriminators before we talk about its bizarre clinical behavior. Run through the profile.
The giant cell tumor profile. Young adult demographic, 20 to 40 years old with closed physes. Epithelial location reaching right up to the subchondral bone of the joint. Classically located around the knee or the distal radius. Radiologically, it is a lytic-eccentric expansile soap bubble lesion. Biologically, it's driven by stromal cells overexpressing RNKL, and it's highly responsive to the targeted monoclonal antibody, denosumab.
Let's lock it in organically for the listeners. Young adult, epiphyseal knee, soap bubble, RNKL-driven denosumab treatment. Now, we staged this tumor earlier using the Enneking system as a benign lesion, but how does it actually behave when you try to treat it surgically?
Well, it's technically classified as benign because it doesn't typically undergo malignant sarcomatous transformation. But locally, it is highly aggressive. It obliterates local bone architecture. And notoriously, if you just perform a standard intralesional curettage, if you just open the cortex and scoop the tumor out, it has an unacceptably high rate of local recurrence.
Because you left microscopic disease behind, like we talked about with the margins.
Exactly. So to combat that, surgeons have to use extended intralesional curettage. You scoop out the bulk, and then you use a high-speed mechanical burr to aggressively grind away the inner walls of the bony cavity, physically destroying those microscopic cells. Or you use chemical adjuvants, like filling the cavity with liquid phenol or liquid nitrogen, to chemically or thermally burn the microscopic disease hiding in the bony trabeculae.
And this brings us to the absolute crux of the GCT, the massive, mind-bending exam trap that we hinted at in the very introduction of this deep dive, the paradox of the GCT metastasis.
Ah, yes. It is the ultimate biological quirk. We have spent this entire time defining GCT as a locally aggressive but fundamentally benign tumor. Yet in a small but clinically significant percentage of cases, historically around 2 to 3%, a giant cell tumor can throw off cells that enter the venous circulation, travel to the lungs, and form distinct macroscopic metastatic deposits.
Let me stop you right there, because I have to ask the question that every single candidate wrestles with when they first study this. If a tumor physically detaches from the distal femur, survives the sheer forces of the bloodstream, travels through the right atrium and ventricle, implants itself into the capillary beds of the lung, and grows into a nodule, how in the world is it still classified as benign? By the very definition of general oncology, metastasis is the ultimate hallmark of a malignant process. It should be an automatic Enneking stage 3.
It feels completely counterintuitive, I know. It totally challenges the rigid definitions we learn. But the answer lies in the distinction between the physical act of transport and the subsequent biological behavior in the new host tissue.
Okay, unpack that.
Yes, the cells physically transport to the lungs. We call it benign transport. But when these GCT cells arise in the lung parenchyma, they do not behave like a malignant high-grade sarcoma.
What's the difference in behavior?
Well, if a high-grade osteosarcoma metastasizes to the lung, those cells are wildly aggressive. They will multiply uncontrollably, rapidly destroy the lung tissue, invade the pleural lining, compromise respiratory function, and ultimately kill the patient in very short order.
Right.
But these benign pulmonary metastases from a GCT often just arrive in the lung, form a small, well-circumscribed nodule, and simply sit there. They are biologically indolent. They retain their benign, well-differentiated cellular characteristics, even in the lung environment. they don't typically undergo rampant destructive growth.
Huh.
In fact, some of them spontaneously regress or just ossify into tiny harmless pebbles. Many of these patients live completely normal, asymptomatic, full-length lives, with these nodules just sitting quietly in their lungs, completely unaware they are even there.
That is truly mind-blowing. The behavior of the cell's internal machinery remains benign, even though its geographic location suggests malignancy. It perfectly illustrates why musculoskeletal oncology is its own unique beast.
Absolutely.
So if you only keep one thing in your mind regarding the giant cell tumor, make it this. GCT is an epiphyseal soap bubble lesion in a young adult. It is Arankel-driven, treatable with the targeted drug denosumab, and it is locally aggressive with a bizarre habit of benign pulmonary metastasis.
Yeah, remember that benign lung metastasis quirk.
Mhm.
It is an examiner's favorite trap.
Moving on from the knee, we are leaving the appendicular skeleton completely and moving to the absolute extremes of the axial spine. We are looking at a very specific, deeply dangerous midline tumor, the chordoma.
The chordoma is a fascinating masterclass in how early human embryology can really come back to haunt you decades later in adulthood. To understand why a chordoma happens, and specifically where it happens, you have to thoroughly understand where it comes from. It originates from notochordal remnants.
Okay, let's trace this back. What exactly is the notochord in the developing human embryo?
When you're a tiny developing embryo, long before you have a bony spinal column or vertebrae, your body forms a primitive, flexible, rod-like structure straight down the midline of your back called the notochord.
Straight down the middle.
Right, it's the primary structural axis of the embryo, and it provides the crucial chemical signaling that tells the surrounding tissues to organize into the neural tube and the spinal cord. As fetal development progresses, the bony vertebral bodies, the sclerotomes, form and ossify completely around the notochord. Once the bony spine is built, the notochord's job is done, and it mostly regresses and disappears.
Mostly regresses. What parts normally survive into adulthood?
In a normal, healthy adult, the only remnants of that embryonic notochord are the squishy, gel-like, shock-absorbing centers of your intervertebral discs, the nucleus pulposus.
Okay.
However, in some unfortunate individuals, microscopic clusters of this primitive embryonic notochord tissue fail to regress properly during development. They get left behind, stranded in the bone.
And where do they get stranded? Because this is the key to the clinical presentation, right?
Exactly. Because of the complex way the cranial and caudal ends of the embryo sold and develop, these cellular remnants are almost exclusively trapped at the absolute far ends of the axial skeleton.
The far ends.
Yes, over 50% of all chordomas occur at the sacrococcygeal region, the absolute bottom end of your spine, the sacrum, and the tailbone. This is by far the single most common anatomical site.
And the second most common.
The second most common site is the spheno-occipital region, specifically an area called the clevus, which is up at the very base of the skull, the absolute top end of the spinal column. Only a tiny fraction, maybe 10 to 15%, happen in the mobile, true vertebral spine in between.
I love this developmental quirk. It really begs for an analogy to visualize it. It is exactly like a construction crew building a massive skyscraper.
Let's hear the skyscraper.
So the notochord is the temporary central scaffolding they use to build the main elevator shaft. When the skyscraper is finished, the crew packs up the scaffolding and takes it away, but they are sloppy. They clean up the middle 50 floors perfectly, but they leave a bunch of metal pipes and wooden planks forgotten deep down in the basement, and another pile of junk abandoned way up on the roof. Decades later, that leftover scaffolding at the roof and in the basement starts causing major structural trouble.
That is a brilliant and highly accurate way to visualize the distribution. The sacrum is the basement, the clivus is the roof. And the defining non-negotiable feature is that these tumors are almost always strictly in the midline, exactly where that central scaffolding used to be.
Midline, roof, and basement. Now, what about the histology? When the pathologist looks at this embryonic tissue under the microscope, what is the specific cellular buzzword the exam loves for the chordoma?
The defining histological buzzword is the physioliferous cell. Physioliferous. It comes from Greek roots, and it translates literally to bubble-bearing.
Bubble-bearing, physioliferous.
Under the microscope, these large tumor cells look incredibly distinctive. Their cytoplasm is completely packed with frothy, clear bubbles or vacuoles, which are actually tiny sacs filled with mucin. If you are reading a multiple-choice question stem and your eyes hit the phrase physioliferous cell or bubble-bearing cell, you immediately stop reading, you lock in chordoma, and you move on to the next question.
Let's do a quick organic recap of those chordoma discriminators for the listener on the go. Let's hit them twice.
Okay, the chordoma profile originates from embryonic notochordal remnants. It is a strictly midline lesion. The most common anatomical site is sacrococcygeal at the base, followed by the clivus at the skull base. And the histological signature is the physioliferous or bubble-bearing mucin-filled cell.
Notochord, sacrum, midline, physioliferous. Let's talk about the clinical reality. How does this tumor actually behave, and why is it so notoriously difficult for surgeons to manage?
Well, biologically, it is a very slow-growing tumor, which at first glance sounds reassuring to a patient.
Sure.
But its slow growth masks a relentless, locally destructive nature. Over years, it slowly and quietly eats away at the massive bone of the sacrum, or the delicate bone of the skull base, invading outward into the sacral nerve roots, the bowel, and the bladder structures. Patients often present very late, complaining of insidious bowel or bladder dysfunction because the tumor has grown massive before causing severe pain.
That's terrifying.
And crucially, and this is a heavily tested oncology concept, chordomas are remarkably radioresistant to conventional external beam radiotherapy.
Let's explore the mechanism there. Why is a slow-growing tumor resistant to radiation? I thought the entire point of radiotherapy was to kill cancer cells.
It comes down to cell cycle kinetics. Conventional fractionated radiation therapy works primarily by inducing catastrophic DNA damage in cells that are actively and rapidly dividing cells caught in the mitotic phase of the cell cycle.
Ah, and because they're slow.
Exactly. Because chordoma cells multiply so incredibly slowly, a vast majority of the tumor cells are resting in the G0 phase at any given time. They are not dividing, which makes them much less vulnerable to that specific type of radiation-induced DNA strand breakage. So, standard radiotherapy often fails to halt the tumor.
Which puts the entire burden of a cure back onto the orthopedic surgeon.
Exactly. Because radiation is ineffective, the definitive treatment goal must be a massive surgical excision. You have to achieve a wide en-bloc resection, taking the entire tumor mass out in one solid, unbroken piece, entirely encased in a cuff of healthy margins.
But consider the anatomy there. The tumor is living inside the sacrum.
Right. To get a wide margin, the surgeon often has to perform a secrectomy, amputating the lower half of the spine. This means deliberately cutting and sacrificing the sacral nerve roots. The patient will likely lose normal bowel and bladder control permanently and may lose motor function in their lower legs. Achieving wide margins in the sacrum or the skull base is incredibly technically demanding, highly morbid, and just devastating for the patient's quality of life.
And if they simply cannot get a wide margin because the tumor is wrapped around the brainstem or the upper sacral nerve.
In highly specialized tertiary oncology centers, if wide surgical margins are anatomically impossible, they will utilize proton beam therapy. Proton therapy is fundamentally different from conventional X-ray radiation. It utilizes a beam of heavy protons that can be engineered to deposit a massive, intensely destructive dose of kinetic energy at a very precise, predetermined depth known as the Bragg peak, minimizing the collateral damage to the surrounding vital nerves and organs.
It is a devastating disease process. If you only keep one thing in your mind regarding the chordoma, it is a midline notochord-derived tumor most commonly found in the sacrococcygeal basement, characterized by physioliferous cells. It is slow but relentlessly destructive, highly radioresistant, and demands morbid surgical margins.
Yeah, it's a truly challenging clinical entity.
Which brings us to our final named condition for this deep dive. We are shifting gears entirely. We are moving away from tumors that originate inside the bone, and we're looking at a bizarre invader that lives exclusively inside the joint space. Pigmented villonodular synovitis, or PVNS.
PVNS. Now, a point on nomenclature for the modern exam. You will increasingly see this condition referred to in recent literature and pathology reports as tenosynovial giant cell tumor, or TGCT.
TGCT.
But the classic acronym PVNS is still heavily relied upon in clinical shorthand and older exam banks, so you must recognize both. Crucially, this is not a primary bone tumor. It is a proliferative disorder of the synovium, the delicate lining of the joint capsule.
Let's break down the normal physiology first. What is the synovium actually supposed to do, and what happens to it in PVNS?
Normally, the synovial membrane is a paper-thin, delicate, almost translucent layer of tissue that lines the inside of a joint capsule. Its only job is to secrete a tiny amount of viscous synovial fluid to lubricate the articular cartilage.
Just a little lubrication.
But in PVNS, That membrane goes completely rogue. It undergoes massive, localized hyperplasia. It thickens dramatically into huge, fleshy, nodular, villous fronds that physically fill up and choke the empty space inside the joint cavity.
Gross.
And crucially, this overgrown tissue is highly vascularized and incredibly friable. It bleeds at the slightest provocation. The patient will present to your clinic with recurrent, massive, atraumatic, bloody effusions. Their joint just keeps spontaneously swelling up tightly with blood for no apparent mechanical reason. They haven't suffered a sports injury, they haven't fallen, they don't have a bleeding disorder.
The name itself is a massive clue, right? Pigmented villonodular synovitis. Where exactly does the pigment come from?
The pigment is a direct result of the chronic bleeding. Because that hyperplastic synovium is constantly leaking microhemorrhages into the joint fluid, the local immune system reacts. Macrophages flood into the synovial tissue to clean up the mess. They phagocytose. They eat the loose red blood cells. They break down the hemoglobin and store the residual iron internally as a pigment called hemosiderin. Over time, because there is so much chronic bleeding, the entire massive, overgrown synovial lining becomes heavily laden with hemosiderin, staining the tissue a dark, rusty, yellowish-brown color.
That makes perfect biological sense. But the examiners aren't usually testing the gross pathology in the operating theater. They test the radiology. What is the classic X-ray clue that screams PVNS?
This is the critical discriminator you must listen for in a clinical vignette. PVNS causes cystic bony erosions on both sides of the affected joint.
Bilateral juxta-articular erosions. It is eating into the bone, but why does it attack both sides of the joint simultaneously?
Because this disease process is driven entirely by mechanical pressure and anatomical containment. The hyperplastic synovium is growing massively, and it is bleeding, creating a huge volume of fluid. It desperately needs physical space. And this brings us to the most important location dynamic for the exam. PVNS is absolutely classic and most destructive in the hip joint.
The hip joint, let's visualize the specific joint mechanics here. Why is the hip joint so uniquely vulnerable to these severe bilateral erosions compared to, say, the knee joint, which also gets PVNS?
It is entirely a function of capsular volume and compliance. The hip joint has a very tight, incredibly thick, rigid, fibrous capsule. There's almost zero extra potential space inside it.
Okay.
When the PVNS synovium starts proliferating and bleeding inside the hip, the mechanical pressure skyrockets almost instantly. Because that tight fibrous capsule will not stretch to accommodate the volume, the diseased tissue has nowhere to expand outwards. So, constrained by the capsule, it takes the path of least resistance. It violently erodes inwards, directly into the softer cancellous bone.
Oh, wow.
And because the diseased synovium wraps circumferentially around the entire joint space, it is forced to eat into the femoral head on one side and bore into the acetabulum on the other side simultaneously.
Okay, I have an analogy for this mechanical concept. Tell me if this works. The hip joint is like a tiny, rigid cast iron lockbox. If you put a heavy-duty balloon inside that lockbox and start inflating it with a compressor, the balloon has nowhere to go. It instantly crushes outward against the metal walls. If those walls were made of bone, the sheer hydraulic pressure would drill right into them.
I agree completely. That is exactly the hydraulic mechanism driving the destruction in the hip.
But the knee joint is anatomically different. The knee is like a large, loose canvas duffel bag. If you inflate a balloon inside a duffel bag, the bag simply bulges outwards. There is plenty of slack in the canvas, the balloon expands, the bag swells up dramatically, and it takes a very long time before the pressure inside gets high enough to start crushing the actual hard contents sitting inside the bag.
Precisely. The knee capsule is highly compliant. It has massive suprapatellar pouches that can hold hundreds of milliliters of fluid. So, in a spacious joint like the knee, a patient with PVNS will present with massive visible soft tissue swelling and huge boggy effusions clinically. But the actual bony erosions on the X-ray happen much, much later in the disease process because the compliant capsule simply expanded to accommodate the pressure. In the tight hip, the bony erosions are early, severe, and bilateral.
That mechanical difference is brilliant. Now, what about the MRI? We talked about X-rays showing the physical bony erosions, but MRI has a very specific, almost magical finding related to that iron pigment we discussed.
Yes. Because the overgrown synovial tissue is absolutely packed with iron from the hemosiderin, it interacts uniquely with the magnetic field of the MRI scanner. Iron is paramagnetic. On specific MRI sequences, particularly gradient echo sequences, the high concentration of iron causes a localized distortion in the magnetic field, creating a magnetic susceptibility artifact. The radiological term for this is blooming.
Blooming artifact. What does that actually look like visually to the radiologist?
It looks like a dark black void or a severe signal dropout on the scan that artificially appears to flare out, or bloom, looking much larger than the actual physical deposit of iron really is. The iron is distorting the image around it. If the exam stem mentions a young patient with a swollen joint and the MRI shows a blooming artifact on gradient echo sequences, you immediately lock in PVNS, or tenosynovial giant cell tumor.
And the definitive surgical treatment for this rogue lining.
Surgical synovectomy. The surgeon has to open the joint, or use arthroscopy, and meticulously try to strip all of that hyperplastic diseased lining out of the joint capsule. But it is notoriously difficult to eradicate every single cell of abnormal synovium, especially hiding in the tight, complex recesses of the hip or the back of the knee, so PVNS has a frustratingly high rate of local recurrence. Often these joints are so mechanically destroyed by the pressure erosions that the young patient ultimately requires a total joint replacement.
Let's do our organic repetitions for PVNS. Let's cement the profile one more time for the listener.
The PVNS discriminators. It is a hypertrophic proliferation of the synovium, heavily laden with hemosiderin pigment from chronic bleeding. Clinically, it presents with recurrent atraumatic bloody effusions. Radiologically, it causes cystic bony erosions on both sides of the joint space. It is classically worst and earliest in the tight capsule of the hip. And the MRI signature is a blooming artifact on gradient echo sequences due to the iron.
Hemosiderin, bloody effusion, bilateral erosions, tight hip, bleeming on MRI. Got it. If you only keep one summary thought for PVNS, it is a hemosiderin-laden synovial proliferation that acts like a hydraulic press inside the joint, causing bloody effusions and bilateral erosions, classically destroying the hip and lighting up with a blooming artifact on MRI.
If you see bilateral hip erosions coupled with a bloody joint aspirate, you absolutely have your diagnosis.
And with that, we have reached the end of the core didactic material for this module. We've built the Enneking framework, we've defined the surgical margins, we've navigated the immense dangers of the biopsy tract, and we've applied all of it to the giant cell tumor, the chordoma, and PVNS.
It's a lot of ground.
But before we let you get back to your drive, your commute, or your chores, we are going to do the lightning round recap. This is a rapid-fire, high-intensity, fast-lap Q&A to stress test your recall. I will ask the clinical question, and our expert will provide the punchy, definitive answer. No deep explanations here, just the raw facts. Listener, I want you to try and answer these out loud in your car or your kitchen before the expert does. Ready?
Ready? Let's run it.
The benign Enneking stages.
Stage 1 latent, Stage 2 active, Stage 3 aggressive.
A giant cell tumor that is contained within the cortex with no fracture. What exact stage is it?
Stage 2 active.
The malignant Enneking staging.
Roman numerals, a low grade, a Fignet high grade, 3 metastatic, letter A inside the compartment, letter B outside the
We're
compartment.
going to get 4 sequential surgical margins.
Intralesional, marginal, wide, radical.
The cardinal limb-saving rule for placing a biopsy incision.
It must be a longitudinal incision, placed strictly in line with the future definitive incision so the entire contaminated tract can be safely excised.
Giant cell tumor, classic anatomical location, and the specific targeted drug.
Epiphyseal, reaching the joint, classically around the knee. Driven by Arayan Kale, treated with denosumab.
Chordoma, the embryonic origin, the commonest anatomical site, and the signature histological cell.
Originates from the notochord, most common in the sacrococcygeal region. Signature is the physioliferous or bubble-bearing cell.
PVNS, the classic radiological X-ray clue, the most vulnerable joint, and the MRI finding.
Cystic erosions on both sides of the joint, most destructive in the hip. Blooming artifact on gradient echo MRI.
Brilliant. We have covered a truly massive amount of clinical ground today. But if we pull all the way back from the cellular details, remember our opening hook. This landscape is murky and dangerous. Musculoskeletal oncology fundamentally comes down to those 2 anchor questions: deciphering the biological staging behavior so you know exactly what the enemy is doing, and planning the mechanical margin so you know exactly how far away to stay when you cut it out. And all of it is anchored by that highest stakes, knife-edge step of the biopsy.
It is a rigorous, unforgiving logical progression. And before we close the show, I really want to leave the listener with a final, overarching philosophical thought to mull over while you finish your drive or fold that last shirt.
Let's hear it.
Think back to the vocabulary we use in medicine. Consider how the standard labels of benign and malignant can be dangerously, fatally deceptive in orthopedics. From day one of medical school, we are trained to hear the word benign and feel an immediate sense of relief. We tell the patient, Good news, it's benign, and everyone breathes easier.
Right.
But when a benign giant cell tumor has the biological capability to send viable metastases to nest permanently in your lungs, or when a benign condition like PVNS can exert so much unrelenting hydraulic pressure that it crushes and permanently destroys both sides of your hip joint in a 30-year-old, it forces you to recalibrate your entire clinical mindset.
It really does.
In the realm of musculoskeletal oncology, benign absolutely does not mean harmless. Benign simply means that the tumor plays by a slightly different, slower set of rules than a high-grade explosive sarcoma. It is your ultimate job, as the examining surgeon, to know those specific rules intimately. Because if you relax, if you underestimate a benign aggressive lesion and you scrape it out with the wrong margin, it will recur, it will destroy the anatomy, and it will take the patient's limb just as surely as a malignancy would.
That is a phenomenal, sobering point to end on. The standard vocabulary can lull you into a false sense of security, but the raw biological and mechanical reality never lies. You have to treat the behavior, not just the label. Thank you so much for joining us on this deep dive. Next time, we tackle the grand finale of this FRCS revision series. We are diving into the module that everyone dreads: statistics, evidence-based medicine, and theater science. Those are the dry, free marks that everyone skips in their revision, but we are going to decode everything from choosing the exact right statistical test for a paper to the literal physics of radiation, diathermy, and tourniquet pressures in the operating theater. You will not want to miss it.
Best of luck with your revision this week. Trust the frameworks and stay focused.
Keep moving forward. We will see you on the next deep dive.